Diabetes for clinical resident. Diabetes is a growing global health concern characterized by the body's inability to release insulin or a resistance to insulin's actions. This chronic condition affects millions and can lead to serious health complications if not managed properly. Patients with diabetes may be asymptomatic, particularly in the early stages. However, acute symptoms can manifest, including polyuria, increased urination; polydipsia, increased thirst; polyphagia, increased hunger; diabetic ketoacidosis (DKA). In DKA, patients may present with ill appearance, acetone breath, cosmal breathing, deep, rapid breathing, somnolence, drowsiness. When evaluating hyperglycemia, consider the following differential diagnoses: hyperglycemia due to physiological stress, diabetes mellitus, non-ketotic hyperglycemia, hyperosmolar hyperglycemic state HHS, HONC, diabetic ketoacidosis in adults and children, cerebral edema associated with DKA, diabetic foot infections, diabetic peripheral neuropathy, conditions such as hemochromatosis or iron toxicity, sepsis. Diabetes mellitus is typically diagnosed through laboratory tests, including complete blood count (CBC), basic metabolic panel (BMP), ketone testing, urinalysis (UA). A diagnosis of diabetes can be established if at least one of the following criteria is met: 1. HbA1c 6.5%. 2. Fasting plasma glucose (FPG) is greater than or equal to 126 mg (DL 7.0). 2-hour plasma glucose is greater than or equal to 200 mg (DL 11.1 moly/L) during an oral glucose tolerance test. 4. Random plasma glucose to 100 mg (DL 11.1 mol/L) in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis. In the emergency setting, there is often no need to treat elevated glucose levels, particularly in cases of non-ketotic hyperglycemia. For conditions like HHS or DKA, specific management protocols should be followed. For outpatient management of type 2 diabetes, the first-line treatment is metformin, starting at 500 mg twice daily and increasing to 1,000 mg twice daily as tolerated. If additional control is needed, glipizide may be added, starting at 2.5 mg twice daily and increasing to 5 mg twice daily with careful monitoring for hypoglycemia. A third agent, such as pioglitazone, can also be considered. If control remains inadequate after 3 agents, insulin therapy should be initiated. Asymptomatic patients or those with non-ketotic hyperglycemia can typically be discharged with follow-up appointments scheduled with their primary care physician. Understanding diabetes' clinical future, differential diagnosis, evaluation, and management strategies is crucial for effective patient care. With proper monitoring and treatment, individuals with diabetes can lead healthy life and minimize complications. Thank you for your attention.